Welcome to LexCura Clinical Insights, the podcast where clinical evidence, healthcare standards, and litigation strategy come together. I'm Michelle Carroll, founder and chief clinical strategist of LexCura Summit. Patient education is a required part of skilled home healthcare, but the documentation must show more than a generic statement that teaching occurred. The record should identify what was taught, how the patient responded, and whether the patient or caregiver demonstrated meaningful understanding. When the notes are repetitive, boilerplate, or inconsistent with the patient's cognitive limitations, the documentation may raise serious questions about whether the education actually occurred. Those inconsistencies can become both a liability issue and a credibility issue. In this episode, I will explain what adequate patient education documentation should contain, how to recognize possible fabrication or clinically implausible charting, and how these failures can support negligence and credibility arguments in a home health case. Okay, so here's something to think about. In home healthcare, patient education isn't just a nice to have, it's legally required. But what happens when the documentation for that education is fabricated or just plain wrong? That's what we're diving into today.
Oh, that's a big one. I mean, patient education is supposed to be the backbone of home health care, right? It's what helps patients manage their conditions between visits. But if the documentation is off, it's not just a clinical issue, it's a legal one too.
Exactly. And what's surprising is how often this happens. Michelle Carroll pointed out that in the records she reviews, fabricated or templated education notes are far more common than most people realize. It's not just a one-off problem, it's systemic.
That's wild. So what does adequate education documentation even look like? I mean, what's the standard that these records are supposed to meet?
Well, under CMS guidelines, it's pretty specific. The nurse has to document what was taught, who received the instruction, how they responded, and whether they demonstrated understanding. It's not enough to just write medication education provided. You need to include details. What medication, what side effects, what to do if something goes wrong. It's all about specificity.
And when that specificity isn't there, that's when things start to look suspicious, right? Like if every note says the exact same thing, week after week.
Exactly. That's one of the biggest red flags. Boilerplate language. Real patient education evolves. Patients ask different questions, their understanding changes, and their conditions fluctuate. If the documentation doesn't reflect that natural variation, it's a sign that something's not right.
And it's not just about the lack of variation. It's also about internal contradictions in the record. Like when a patient is documented as having moderate dementia, but the education notes say they verbalized understanding of a complex medication regimen. That's just not possible.
Right, and that's what Michelle called cognitive inconsistency. It's one of the strongest indicators of fabrication because it creates an internal contradiction in the chart. If one part of the record says the patient is cognitively impaired and another part says they understood detailed instructions, it's clear that something doesn't add up.
And then there's the issue of caregiver presence. If the notes say the patient lives alone and no caregiver is present during visits, but the education documentation says instruction was delivered to patient and caregiver, that's another big red flag.
Exactly. That's what Michelle called caregiver presence inconsistency. It's a factual error that you can point to and say, this didn't happen. And once you've established that, it opens the door to questioning everything else in the record.
So it's not just about proving one failure. It's about undermining the credibility of the entire record. That's a powerful tool in litigation.
It really is. And it's not just about credibility. These documentation failures have real clinical consequences. Patient education is what bridges the gap between visits. It's what gives patients the tools to recognize warning signs, manage their medications, and make informed decisions. When that education doesn't happen, or when it's documented but wasn't actually provided, it can lead to harm.
Like the examples Michelle gave, The patient who wasn't told not to take two blood thinners simultaneously and ended up with a bleeding event. Or the patient who didn't know the warning signs of a wound infection and ended up with sepsis. In both cases, the failure to educate directly contributed to the harm.
Exactly. And that's where the causation argument comes in. What should the patient have known? What would they have done differently if they'd been adequately educated? And would that have prevented the harm? It's a clear way to connect the dots.
And it's not just about individual cases. When you see a pattern of fabricated education documentation, it points to a systemic issue. That's where you can start to build an argument for punitive damages. It's not just negligence, it's a conscious disregard for the standards of care.
Right? And that's why Michelle's practical guidance for attorneys was so valuable. Isolating the education documentation, cross-referencing it with cognitive assessments and caregiver presence records, looking for systemic patterns. These are actionable steps that can make a real difference in how cases are evaluated and litigated.
And it's not just about litigation. This kind of analysis can also drive improvements in clinical practice. When agencies see how these documentation failures are being scrutinized and used in court, it creates a strong incentive to get it right. Better documentation means better care, and that benefits everyone.
Absolutely. And I think the takeaway here is that education documentation is one of those overlooked areas that can have a huge impact when you know what to look for. It's not just about meeting regulatory requirements. It's about ensuring that patients have the knowledge they need to stay safe and manage their conditions effectively.
And for attorneys, it's about recognizing the dual value of these failures in litigation. They're not just a causation argument, they're a credibility argument. When you can show that the documentation is fabricated or clinically impossible, you've got a powerful tool for undermining the defense's case.
Couldn't agree more. It's one of those areas where clinical intelligence really intersects with legal strategy in a way that can change the outcome of a case. And the more we understand about how to identify and use these failures, the better equipped we are to advocate for patients and hold providers accountable.
Well said. I think this is one of those topics that's going to stay relevant for a long time, especially as the demand for home health services continues to grow. The stakes are high, and the need for accountability has never been greater.
Absolutely. It's a reminder that even in something as seemingly straightforward as documentation, there's a lot at play and a lot at stake. Thank you for listening to Lex Cura Clinical Insights. Patient education should be evaluated as part of the patient's overall clinical pathway. The analysis should compare the teaching documented in the visit notes with the patient's diagnosis, cognitive status, functional ability, language needs, caregiver involvement, and subsequent conduct. A statement that the patient verbalized understanding is not enough when the surrounding record suggests that meaningful comprehension was unlikely, or when the same language appears repeatedly without individualized detail. The central question is whether the record shows that education was actually provided, understood, reinforced, and adapted to the patient's needs. When it does not, that failure may support arguments involving inadequate care, unreliable documentation, and loss of credibility. For more clinical intelligence, litigation analysis, and practical guidance, visit LexCura Summit at lexcurasummit.com. I'm Michelle Carroll. Thank you for joining me, and I'll see you in the next episode of LexCura Clinical Insights.